Excellent. So the paradigm shift brought on by transcatheter valve therapies began with aortic stenosis. We may all remember the partner trial back in 2010 when aortic stenosis patients that were inoperable had a very hard time in the last months of their lives and a very hard death. And partner trial initially was for the inoperable, and it brought on a therapy for the inoperable through transcatheter aortic valve insertion, which made a big difference to treatment of heart valve disease. Certainly because aortic stenosis is very common, is the most common valve disease, particularly in the elderly with comorbidities. The progress in evidence for this paradigm shift is more established in the case of aortic stenosis. I did not bring a slide for the partner 2, but partner 3 trial already moved to low surgical risk and still demonstrates benefit of transcatheter aortic valve insertion compared with surgery, even in the low surgical risk patients, and then obviously allowed envisaging early treatment of aortic stenosis with a very low risk therapy that TAVI is. You can consider TAVI for the asymptomatic, and you already know this trial published in 2024, late in 24, in New England Journal of Medicine, transcatheter aortic valve insertion in asymptomatic patients with severe aortic stenosis. And there is a benefit in them as well, again, because of the existence of a large proportion of patients with aortic stenosis in the elderly. There was a lot of assessment of evidence brought on regarding the structural damage, apart from the aortic stenosis, the structural damage of the heart as a result of aortic stenosis in these patients, and also evidence regarding the possibility of sudden death, which is there with severe aortic stenosis, even in the absence of symptoms, and explains why early intervention can help, even just immediately in the short term. I believe that if we were to be able to assess in the long term what happens with those patients and to have large populations of patients, we will find significant benefit in the long term, particularly in the younger group of patients with severe aortic stenosis, by avoiding the myocardial damage and the consequences, the hemodynamic consequences on both the left and eventually the right heart in these patients. So is it all about aortic stenosis? We need to move on with this paradigm shift towards other types of valve disease to be more daring. Firstly, recently we had transcatheter therapy for pure aortic regurgitation as well, and this allows consideration of paradigm shift in this regard. We know that severe aortic regurgitation, although is less prevalent than severe aortic stenosis, and cases are more less concentrated in one clinic, in around one operator. We know that actually looking into this patient's category, they have a higher mortality. They have the highest mortality of all patients with heart valve disease if they are symptomatic, and particularly if they are severely symptomatic. From New York Heart Association Class 3, you see that mortality is almost 1 in 4. So it's absolutely very significant mortality. But even in the asymptomatic patient, you have almost 3% mortality in patients with aortic stenosis, with aortic regurgitation. So why is aortic regurgitation forgotten? And I think tricuspid regurgitation used to be the forgotten valve, and at the moment, aortic regurgitation is in the process of being less forgotten and being more in the highlight, in the spotlight for investigations, because we have a bias which is caused by the aortic regurgitation in the young. which is the aortic regurgitation caused by bicuspid aortic valves, which is a condition that progresses very slowly from being just a valve which is dysplastic to being a valve which is dysplastic and severely dysfunctional, and subsequently with having immediate consequences. And because also the evidence, you can see even in this study, that this is published in 1999, so evidence is very old, that evidence that encourages us to follow up patients with aortic regurgitation without offering valve intervention comes from the times when treatment with surgery was higher risk than actually just follow-up, although things we know have progressed a lot in cardiac surgery as well regarding safety of procedures in patients with aortic regurgitation. So because transcatheter therapies allow us a paradigm shift towards an older population and a population that has more comorbidities and a higher surgical risk, we have this recently published beautiful study from Cleveland Clinic Foundation, which looked into what happens with the ventricles of individuals that are older, and they also looked at women. So practically, because of this bias of waiting for the ventricle to dilate and to drop ejection fraction that we had in time from the younger patients with bicuspid aortic valve in all the times, we did not observe that actually the left ventricle does not remodel the same in the elderly and in women. So the ventricle does not dilate. So we should not wait in individuals which are over the age of 65, and particularly in women over the age of 65, for the ventricle to dilate, particularly as we now have a low risk treatment for them, which is the transcatheter aortic valve intervention for aortic regurgitation. And why is the ventricle not dilating? There's this beautiful study which was actually old but not observed, not put in the spotlight, that actually the dilatation of the left ventricle is a phenomenon of adaptation to avoid pressure rise, so to avoid symptoms. However, with age, we lose the adaptation to aortic regurgitation. And the pathology of the aortic valve, which causes aortic regurgitation with age, is usually degenerative, is usually calcification of the aortic valve, which does not stenose the valve, it's only retracting the cusp, it causes scarring of the cusp, or is a combination of the two, aortic stenosis with aortic regurgitation. And these individuals beginning their aortic regurgitation at an older age have lost the process of adaptation. And I would like to introduce this idea as well, the fact that it is observed that low flow is not specific for aortic stenosis. So the idea of low flow, so small left ventricular cavity, non-distensible left ventricle, is specific to age rather than specific to aortic stenosis. So it can occur in individuals that have mitral regurgitation, atrial secondary in etiology, in individuals that have aortic regurgitation. And we should not wait for a very large regurgitant volume in these individuals where their entire stroke volume is very small. So it opens our mind. There's a paradigm shift towards looking to move treatment forward to lesser levels of degree. And there is more evidence recently, as observed from this paper published in JACC from Mayo Clinic, that actually adverse outcomes in patients with aortic regurgitation begin to be observed from ejection fraction 60%, not 50% and not 55%, but even 60%, and with a drop in GLS. And even more so, this beautiful study from Patricia Pellica at Mayo Clinic has looked at moderate to severe rather than purely severe aortic regurgitation, acknowledging the fact that nowadays the thresholds for considering aortic regurgitation high are too high. Severe are too high. And my hope is that there will be a paradigm shift in this regard as well. Furthermore, transcatheter therapies will allow a paradigm shift in the treatment of multivalve disease, which is currently really in the spotlight. Why it allows a paradigm shift? Because traditionally, treatment was concomitant. At the time of cardiac surgery, it was perceived as absolutely the right thing to do to treat moderate valve disease that coexists with severe valve disease or coexists with surgical coronary artery disease. However, for transcatheter therapies, we can consider stage intervention. Stage intervention is feasible. You can go back, you can do it, you can be wrong, you can hope that the second disease will resolve. And if it doesn't resolve, yes, you can be wrong, because you can have a second chance to treat the patient with a transcatheter intervention, which is, low risk and low suffering compared with a reduced sternotomy that you may have to offer in case of not treating the less than severe second valve disease. So there are many combinations of valve disease we have to have in mind. Or, as you can see, aortic stenosis with mitral regurgitation, aortic stenosis with tricuspid regurgitation are pretty frequent, and the opposite, mitral regurgitation with aortic stenosis, which I want to highlight, because when we put aortic stenosis with mitral regurgitation, we mean the severe is the aortic stenosis and the mitral regurgitation is coexistent. However, it can be the opposite, that you have severe mitral regurgitation and less than severe aortic stenosis, and that is again something to consider, the type of treatment and the treatment strategy you will use, particularly as you have available transcatheter therapy. So aortic stenosis and mitral regurgitation is the most common combination present in the multi-valve disease arena, and the transcatheter intervention has changed and makes us think deeper, in the sense that we know that mitral regurgitation is secondary in nature. It also made us look better at the valves and actually consider the morphology, consider the etiology of valve disease. Because if you treat the aortic stenosis, mitral regurgitation, which is secondary in cause, can reduce in severity, although mitral regurgitation, which is primary in cause, is not to be expected to reduce in severity, although symptoms may be better and the patient may be able to have the treatment delayed. However, the question starts to rise whether or not we should offer treatment of the aortic stenosis, which currently is the better established, with the best results in more hands all around the world, TAVI for aortic stenosis. To offer that even in less than severe aortic stenosis, or even when the aortic stenosis is borderline severe and we are sure that it is the primary mitral regurgitation that is the main cause of patient symptoms, we may consider or thinking about considering offering TAVI in these individuals to improve symptoms and delay the need for transcatheter edge-to-edge repair, or allow the left ventricle to reverse remodel in order to allow a better result of the transcatheter edge-to-edge repair. We have to also take into consideration that if we leave behind moderate aortic stenosis when we treat the mitral regurgitation, if we have an excellent result of mitral regurgitation treatment, we actually cause afterload mismatch of the left ventricle. So it may be that the aortic stenosis is significant for the patient in the peri-interventional stage and may allow a better preservation of the result if it was treated in the long term. The strategy for transcatheter intervention will depend on valve morphology and also on the severity of disease, and using a multimodality approach in order to establish the severity of the disease, because obviously if we have mitral regurgitation, we cannot characterize the severity of aortic stenosis by echo only. That will be low flow aortic stenosis, and we need a calcium score to characterize the severity of aortic stenosis in these patients, and probably to look into early treatment of the aortic stenosis to allow better treatment of the mitral regurgitation. And indeed, also in secondary mitral regurgitation and in heart failure patients, TAVI can be used to facilitate heart failure treatment. So in low flow, low gradient aortic stenosis, TAVI will not only facilitate the treatment of the second valve disease, it will facilitate better action, better treatment of the heart failure with medical management in these individuals. So my conclusion is that transcatheter valve therapies have caused and are in the process of causing further paradigm shift in the way we organize our strategy for treating heart valve disease. It can currently treat the untreatable by surgeons, the elderly, the frail, the patient with comorbidities. And being low risk, it can treat early without allowing development of secondary consequences on the ventricle and hemodynamics. It can treat in stages, can be easily repeated. It does not need to treat everything at once, and it can treat to facilitate further treatment. Thank you very much.
Wow, that was so concise presentation. I think I will need to watch it 2 or 3 times again when I go home to understand and take in everything you told us in this 10 minutes, Madalena. Thank you very much. Where can I start? Where can I finish? There are so many things you touched upon. Aortic regurgitation is an issue. In my career, I think the patients that fared worst after surgery were those with aortic regurgitation that was really terminal and very delayed presentation. So certainly I think for those patients, transcatheter therapy will give a solution. The obstacle so far was that we didn't have specific devices for aortic regurgitations. Now we have the first one that has CMAC, the trilogy valve, and hopefully this will give us more options in these patients. The problem with these patients is that if they're young, usually they have some anatomic variation in the aortic valve to have aortic regurgitation at a young age. And the only thing I want to ask you and to give us your light is what you said about the dilatation of the left ventricle in aortic regurgitation, that this doesn't happen so much in elderly and in women. And the reasoning behind that was that the stroke volume can be low, and also the properties of the aorta in these people. Can you
the properties of the left ventricle, the ability of the left ventricle to dilate is lost with age. It is clearly demonstrated in a beautiful study that actually caused iatrogenic aortic regurgitation in sheep, young sheep and old sheep. And it demonstrated lack of development of dilatation in the old sheep, which developed symptoms and developed heart failure, although the young sheep developed dilatation of the left ventricle and tolerated the aortic regurgitation that was iatrogenically caused. I am putting that out there because that makes us one, there are many colleagues, cardiologists around the world that are waiting for the elderly with aortic regurgitation to dilate the left ventricle. They tell them, you don't need treatment. Yes. Your heart is not big enough. Your heart is still small. Your heart is holding on. And it's not true because their heart will never dilate. They will be breathless. They will die in heart failure from aortic regurgitation. Also is because the heart is small and the stroke volume is small, the calculations from echo of regurgitant volume, we should be expected to be smaller. So the aortic regurgitation should be expected to be severe at a lower regurgitant volume than it is in the young, which develops a severely dilated bovine heart of the young with aortic regurgitation. So yeah, I think we need to look into aortic regurgitation with more attention now that we have a tool of treating them at low risk. Because I agree with you, the risk remains high in patients with severe aortic, severely impaired left ventricle with aortic regurgitation with surgical treatment. However, the risk is not as high with transcatheter intervention.
And the other thing you mentioned, and it became evident to us now, is that with transcatheter therapies, there is no need to go all over the problems at once. You can delay. So this divides the risks. And in these cases, I think 1 and 1 and 1, it makes 3. But if you go for surgery and to do all this together, then it doesn't go 1 and 1 makes 3, it makes 5 or even 6. Professor Tsoufis, your comment?
Yeah, First of all, congratulations for your amazing talk. We really like it. And we'll learn a lot. And we have, as Costa said, to learn more when we come back to your talk. I completely agree. This is the major advantage of interventional cardiology, not to do everything at once. The problem for the surgeons is that they have to treat at one stage or let's say, the problems. But on the other hand, what we have to do as an interventionalist, we have, let's say, to have a plan in advance for our patients. This is something that in some cases we missed now. We treat, let's say, we have to treat the valve that is first priority due to the severity, but when we select a device, we have also to have in mind what we will do after 3 months or after 3 or 5 years, to have a plan. It's something that we have to take into consideration. Thank you so much.
Absolutely. Thank you. Thank you for inviting me.
And